is unusual for the demographic.
Good morning.
Morning.
How's everybody this morning? Good. Now, I understand where we are and what we're doing. And so I am happy that all of you are at CBCF 2022. I understand the nature of the conversation that we're about to have, the importance of it, how it impacts our community, not only from a policy perspective, from a resource perspective, from an impact perspective, from how our kids show up at school to how our men show up at home to how our women are navigating what it is that they go through on a daily basis. And there is a fundamentally important academic and policy component to this discussion that many of our panelists are going to talk about. But more than anything else, this is about us. This is about who we are. This is about our ability to thrive in our lives versus just survive. It is about how are we reframing being former slaves in America to being independently beautiful spirits that have the ability to maximize that which the Creator put us here to do. And so I hope that we can come into this room with that spirit. I hope we engage each other with that spirit because the policy work and the economic work and the academic work, even the fundraising and infrastructure work that is necessary means nothing if we don't see each other. And it means nothing if we don't love each other. It means nothing if we can't look each other in the eye and have a sense of where we are that day and why it matters. And even in our well-doing, we cannot lose the humanity aspect of what it means for us to be well, what it means for us to be there for each other, what it means for us to love each other, and what it means for us to help each other get to a place where we have the ability to maximize lives that in some cases, many of us have told ourselves will never happen. And so I'm thankful to be the moderator. My name is Jeff Johnson, and I am excited to introduce to you a fantastic panel. I know that they are brilliant, and you should know that they are brilliant because they are here. And because you should know that they are brilliant and that they are here, and because many of you have smartphones, that is why I will not be reading their entire bios, so that we are able to dive right into this conversation, and you can hear for yourself what their bio probably doesn't actually reflect. So we are going to have a conversation not only about the inequities that exist within the field of not only mental health and mental care, clinical space, but how we as a community are able to reimagine what thriving looks like through pushing for equity, through understanding how we diagnose, through having conversations about various demographics, whether it's young people or men, and how we're offering not only legitimate resources, but tactics for families and communities to ensure that as we talk about social justice, and as we talk about police brutality, and as we deal with the prison system, as we talk about education, this is wrapped in all of that. And we do ourselves a greater service by understanding the ecosystem and connectivity versus siloing these kind of conversations in a way that makes us feel like there's a certain group of people that deal with issues of mental health and mental wellness, of therapy and healing, of thriving and overcoming, and other people do other stuff. Because the last I checked, when I go to my kids' school, there's a whole lot of kids in need of engagement, in need of diagnosis, in need of support. There are a whole lot of parents that are in need. When I go to my brothers and sisters who are in colleges and universities, I see the need for engagement. I see the stress levels. I see the anxiety levels. When I talk to my brothers and sisters who are from the hoods to the suburbs, I see the need. I see issues of abandonment. And so if we can, even in our conversation, ensure that we elevate nuance and complexity and how these things intersect, then even those of us that are interested to fully committed will potentially find some partners in this room that we didn't recognize were there, and potentially find some opportunities for connectivity that previously we didn't know that were there. So with that, I am excited to introduce, and each of our panelists will, after this introduction, will provide some introductory remarks to set frame for our conversation. But I would like to introduce all of them. First, I have Bukata Hayes, who is the VP of Racial and Health Equity for Blue Cross and Blue Shield of Minnesota. Really excited to hear how he begins to frame what providers can do and what providers should be doing, and where there are opportunities for partnership and legitimate partnership and investment in our communities. I want to introduce Dr. Tia Dole. She's the executive director of the Steve Fund, and the Steve Fund is doing incredible work around young people and engaging young people and ensuring that adolescents don't get lost within the context of this broader discussion. Dr. Mesa Akbar, who is the Chief Diversity Officer for the American Psychological Association, or APA. And listen, I think that many of us know that there's really some great opportunities for not only partnership, but context for where APA is, what they're navigating, how we're looking at us being in this industry and us not being in this industry, and how we're dealing with institutional racism from even the organizations that are pushing for equity, and excited about what we have to hear. Dr. Harold Woody Neighbors, who is Professor Emeritus, School of Public Health at the University of Michigan, Ann Arbor, and Senior Research Advisor for Hurdle, who is one of our sponsors today. And listen, I love Hurdle. If you don't know Hurdle, I hope that you get to know Hurdle. And I love when we begin to build infrastructure and institution for ourselves, as opposed to waiting for somebody else to do it for us. And so I'm celebrating them. And then last but not least is Ruben Roberts, who's the Chief Executive Officer, of RER Consulting Enterprise, LLC. So I'd love to, let's just start to my immediate right and go to the right.
Thank you. I want to say good morning. My name is Woody Neighbors, and as you just heard, I am a research advisor with Hurdle Health. I have a little bit more to say about that later. I also direct the Man Up, Man Down research program out of the University of Michigan, and I have a lot to say about that during the Q&A. I want to say it's an honor to be here to speak with you about this significant problem. I say it's a problem because I've been studying the mental health of Black Americans since the mid-1970s, and it's a problem that just never seems to go away. On the basis of my research, I'm prepared to answer any and all questions today about help-seeking behavior, the diagnosis and the misdiagnosis of mental disorder, clinician color blindness, and especially the emotional impact of broken dreams. In addition to talking about my research, I want to speak to you today as a Black man who's benefited from being in therapy. Or was it counseling? Or was it treatment? Actually, I don't care what you call it. It helped. Actually, I want all Black men out there in the sound of my voice who are not sure about whether they want to get help for anything. I want you to know that in my deepest and darkest hour, I was not crazy. In fact, crazy is a word that we should strike from our vocabulary immediately. I wasn't crazy, but I was in pain. I wasn't scared. In fact, I was quite brave. The most courageous thing I ever did was admit to myself, and then later to some of my friends, and now to anyone who will listen to me, that I needed and eventually got professional help. Being in therapy made me strong, not weak. It gave me insight into my problems. It gave me knowledge of self. Most of all, it taught me to stop trying to be a tough guy. So the Man Up, Man Down research program is against what we call tough guy syndrome. Man Up, Man Down believes that you can man up some of the time to your problems, but you can't man up to every problem life is going to throw your way. Trying to man up to everything can result in the man going down. But if you're smart and you get the help you need, you can be man up again in no time at all. I think Bill Withers said it as well as anyone. No one can fill those of your needs that you won't let show. Man Up, Man Down says, take off the mask, tell the truth. If you feel something, say something. Thank you.
So it's the second time that I sit next to Woody in one of these, and of course, every time I'm like, great, I'm after him. Good afternoon. Such a pleasure to be here. Kevin, thank you for the invitation. I, of course, love the work that Hurdle is doing and in promoting and exposing the importance of mental health, especially in Black men. I'm the Chief Diversity Officer and the interim chief of psychology for the public interest for the American Psychological Association. APA most recently, within 2 years, established an office for and focused on equity, diversity, and inclusion. I want to give context to that. You're talking about a 130-year-old association, and 2 years ago, they established an office, which I run. So no small feat, right? As soon as I got to APA, I hit the ground running, understanding that, thank you, sir, understanding that we needed to focus on the mental health that was particularly connected and rooted in either perpetuating or discriminating against communities of color. We underwent a huge effort to do a historical chronology that dated 130 years to identify how and where psychology has contributed to the belief in human hierarchy, the belief that because you are of a certain color, complexion, or because you are fitting into the construct of race as superior, then psychology contributed to the understanding that that superior race meant that we were weaker as a community. We apologized for all of the things that we did. Those included our commissions, omissions, or explicitly discriminating against communities of color. A historic moment for the association in October 2021, led by a Black woman who was the president of APA at that time, Jennifer Kelly. We understood that this apology was not going to be enough because an apology without action is pretty meaningless, isn't it? So we have engaged in the last 18 months on a focus to figure out how psychological science can tackle societal issues by not just apologizing, but making sure that we move into action. How can we dismantle systemic racism? In fact, aren't we the experts in human behavior? And aren't humans the one that created it? We have a large responsibility that dates over 400 years. But we must achieve health equity, and we must work on dismantling the systems that created this racial hierarchy and this belief system. Black and brown communities have faced many barriers in access to physical and mental health, stemming from long-term racism that has been faced in this country. Today, I plan to highlight the role of racism and how it has been placed in the DNA and embedded into mental health inequities. Historic racism has contributed to trauma, and I want to make sure that I allow that to sit in this space. And research shows that it has contributed not only to the current trauma that we face, but to intergenerational trauma that we pass down from one generation to another unless disrupted. The Congressional Black Caucus and its allies have a very powerful voice in Congress to advocate for innovative models and to increase funding for trauma-informed care and interventions that meets the needs of people of color. So not something that has been standardized in white communities and then washed down to be applicable to communities of color, but something that is for us and hopefully by us. As each of you are listening today, together we will talk about policy reform, we'll talk about resources, and I will make sure to highlight all of the work that APA is doing, which is easily accessible and adaptable into your environment and into the work that you are doing. Thank you for the invitation, and I hope that we can have a very productive conversation on how psych science can change the way that it looks today so that it can meet our needs for tomorrow.
Thank you so much, Dr. Akbar. Before Brother Bukata goes, I do want to make sure that I recognize that this panel has been imagined and is being hosted by the great Congresswoman from the 20th District of Florida. And Congresswoman Sheila Cherfilus-McCormick is here. I want to make sure that we recognize her and thank her for finding this panel necessary. Thank you.
Well, good morning, everyone.
Good morning.
Thank you so much for joining us. This is one of the first panels to kick off this wonderful conference, and I thank you guys for being here for such an important time and such an important topic. Before I came into Congress, I was the CEO of a healthcare company, served in the capacity for 15 years, and in that position, I realized the disparities that exist, especially when it comes to healthcare. But when we talk about what happens when it comes to mental health, it's an even bigger divide. The acknowledgement, the accessibility is really predicated on how much money you're making, where you're living, but we also live in a community where we have a stigma when it comes to mental health. So what we're doing today is trying to break down the barriers. We have experts here to talk about how we can increase accessibility, how we could talk about how we can take away that stigma and prioritize our mental health, so that mental health screenings are as normal as a physical every single year for our geriatrics, for our seniors, for our kids, and for ourselves. Because too many times we suffer silently, especially as young professionals, young adults. I think I'm young. My kids don't, but we know the struggle. We know what it feels like to always have to perform at a level that's higher than anyone else is expected to perform. And that hence makes us suffer more than any other demographic. So I'm happy to be here, and I thank our host, Jeff, for being here. Thank you so much, Jeff Johnson, for being our moderator. I also want to thank our staff for putting this together. You guys are awesome. And I want to thank Dr. Maisha Akbar for being here today speaking. And Buka, I hope I didn't mess up your name.
Bukata, it's good.
Bukata. People mess up my last name, too. I'm
I
Cherfilus-McCormick.
got you.
Somebody even said Syphilis-McCormick. So don't let me chop it up like that. Then we also have Dr. Tia Dole and Ruben Roberts and Dr. Harold Woody. Neighbors, thank you so much for being here as we continue to go forward. And I always remind everybody that we are really in our destiny moment as a generation. And for us to make this moment great, we have to strategize and make it a reality, how we transform our healthcare system, how we transform mental health, but most importantly, how we make healthcare accessible to everyone, especially people living in minority areas, minority and Black people. That is our job. And I hope that everyone here is up to the task. So by the time we get to that nice gray age, we said, you know what, we did it. We made our destiny moment great, and we changed the face of healthcare, especially mental health. So thank you so much for being here today, and we hope you enjoy the panel.
Thank you so much again, Congresswoman. Brother Bukata, I'd love for you to chime in again from the role of a provider in an institution that is ripe with challenges. I think
absolutely.
has already been mentioned.
Yeah, so appreciate that, Jeff. So Bukata Hayes, Vice President for Racial and Health Equity at Blue Cross Blue Shield of Minnesota. In 2020, Blue Cross Blue Shield of Minnesota declared racism a public health crisis. And through that declaration, we committed to do some things about it. I do want to put context around that, though, right? If we think about 2020, Minneapolis, Minnesota, the murder of George Floyd, right? Trauma, pain, tragedy that was associated with that. And then we understand COVID disproportionately impacted Black community, from who caught it, who was hospitalized with it, who died from it. It then also impacted who could isolate, quarantine, learn online, work online, all these other things. And so it was in that context that we made that declaration. And so part of my work is to figure out how we change our system so that we provide access to critical opportunities like Hurdle? How do we continue to provide access to racially concordant care, the for us, by us? How do we connect Black folks with Black practitioners? How do we create those avenues that someone understands both depression and anxiety, but understands racism and its impacts on the body? And I'll just share a quick story to speak about that, but coming through school was looking at the risk factors for heart disease. This was in 1997 as I was getting my degree. And they run down the list factors, right? Smoking, sedentary, high blood pressure, Black, right? And then they go to the next one, right? Obesity. And I remember asking the question, wait, what do you mean Black, right? This is 1997. And the professor said, yeah, unfortunately, if you are Black, you're at higher risk for heart disease, right? That was the understanding then. I think now we know, right, through a lot of great research, that it was racism, that it was being Black in a suffocatingly racist system that caused high stress, and that high stress has physiological things that it does to our body. That's what it was. And so the idea of how do we continue to center that as we as a payer, right? We are health plan. How do we center that as we think about ways in which we reconcile and provide resolution to those issues? And so mental health, culturally responsive, trauma-informed mental health is one of those ways in which we're doing that. George Floyd was murdered in 2020 in Minnesota. We had another young man that was murdered, Dante Wright, in interaction with police. And that community was Brooklyn Center. And so one of the things we did, and I'll talk about it more, is we opened up free access to teletherapy, culturally responsive teletherapy sessions in that community for those who wanted it. As a payer, I think we have to think about how we do those things to provide access and be responsive and relevant in the moment. And that's what I'll continue to talk about and share. Just really appreciate being here. I will say, as I'm here, right, Minnesota, the epicenter for sort of racial protests, as I'm here today, there is a planned strike of mental health workers in Minnesota. The system is like at its breaking point. And I think that's why we have to be urgent about this moment we're in.
Great.
Thank you.
My name's Tia Dole. I'm a clinical psychologist, and I am the executive director of the Steve Fund, which is supporting young people of color in mental health. And I thought about listening to you all, and I switched what I was going to say while you all were talking, so I hope you don't mind, because I don't need to repeat the same thing. I thought I would tell the story about when I was a young person, 25 years ago, living in Atlanta. I was a research assistant. I wanted to go to a PhD program, so I was volunteering at Grady Memorial Hospital, which I don't know if folks are familiar, nicknamed Shady Grady. It's a community-based hospital that is a safety net for folks. And I was working on a research study on suicide for Black folks. And my job was to talk to people after they had made a suicide attempt in the emergency room. I think one of the first person I spoke to was, she was laying in a hospital room. She had swallowed Tylenol with bleach, and she woke up in the hospital bed crying with chalk. You know, they put the charcoal to help you vomit up all the things you've ingested. Charcoal all over her face, and she woke up crying because she didn't succeed. She's a Black woman with a substance use issue, poorest people in Atlanta. And I thought to myself, we are failing her. I have to help. And that started my pathway in working with people who are suicidal, and working with people with substance use, and working with young people that impacted the trajectory of my life, because to your point, I saw her as a person. She wasn't a research subject. She was devastated that she was going to live. And I knew in that moment that something needed to change. And so I guess I'll say here now, 25 years later, that I'm excited about where we are as a mental health field, it's still trash, to your point, right? But it is better because we're all acknowledging where we are. And I actually see in young people a shift, a rejection, a mobilization of the status quo. And so my hope is that I will continue to increase my hope as I see us all adult allies standing behind young people, standing behind each other to call out the fact that there are mental health issues in communities of color, in Black communities, and there's lots of reasons why, and that we have to face them head on.
Thank you, Dr. Dahl. And thank you, everybody, for your opening remarks. We should actually call this panel Taking the Trash Out. Because, I mean, technically that's where we are, right? How are we removing all of these things that you all talked about to ensure that there is a system that actually sees us, serves us, and provides us with what we need? And listen, I almost laughed out loud when Bukata, you said that in 2020, you all said racism was a public health crisis. Like, for real?
Yeah, I know.
How eye-opening and revolutionary for y'all to do that in 2020.
Hey, that's why I said the context.
No,
man,
I
so that
got
folks
you. I got you. I just
too
wanted to make
radical.
sure I
Yeah,
acknowledge
you
the
got it,
obvious for those that missed it. That's not something to celebrate.
Right.
And in fact, the fact that a provider in 2020 thinks that making that announcement in some way, shape, or form is a good thing, in many cases speaks to some of the greater challenges, right? So I'm curious as we talk about access, because let's start there. Let's just start with, before we start talking about misdiagnosis and diagnosis, before we start talking about stigma, before we talk about that, let's just talk about the fact that there are people of color, poor people that want access to mental health care, resources, tools that can't get them. And we recognize that there's systemic racism that is at the root of that. As a provider, what are the metrics? Because 2020 provided a whole lot of statements and not a lot of litmus to back those statements up. And so, because you're here, let me put you on the spot. Blue Cross Blue Shield, Minnesota. What are the metrics that you all are using to determine that you're actually moving in the right direction? And because in many cases, a lot of folks who have actually done the work have realized that their early metrics, they didn't know what they didn't know. So I'm also interested in, as you set those metrics, what were things that you learned that said, wait a minute, we don't know what the hell we're talking about, and where some of those shifts took so that the metrics you're actually using to talk about increasing access are legitimate.
So a couple of things. One, I would say, again, we are, this is the first ever sort of position at my enterprise. So to the point of 100 and some odd years, we've been 90 years in existence in Minnesota. And it was in 2020 we did this. A couple of things that I think are really important from my vantage point. And so one is the old metrics won't get us out of this. I think we have to stop using the old metrics. I think we have to create new metrics. And so I do know that there's a sort of a new metric, right? It's the multidimensional measurement for structural racism done by Dr. Rachel Hardiman at the U of M School of Public Health. That's a new measurement that is centering racism, saying racism is the reason we're experiencing much of this. And so I think it's more efforts and initiatives like that. I would also say around metrics that for the most part, none of the metrics we've used up to this point has got us the results that we wanted. And so for me, I think one of the things that we're trying to do is simply, we believe community has the answers. So the idea, how do we engage in community, listen and respond? So part of our work with Hurdle in Minnesota was community said, we need access. So then what we did is we said, hey, we know a culturally responsive teletherapy, let us find a way to just open up access. Don't have to be a member, don't have to have insurance. Here's dollars to access services to move forward. And then the other thing is we need more Black and brown practitioners. So if there's any metrics we're using, it is, what does our network look like? Right? How are folks engaging in the services that we're providing? Are we responding in community as we should? So I think for me, those are the metrics that I see that we are using as a plan and a provider. And I believe it's metrics and investment and partnership that has to happen, because that has never been there. Right, so I think that'd be my answer as Minnesota.
I
right?
appreciate you responding to the pressure, because I was coming for you again because I didn't hear him at first. But to be fair, this is new. You don't change 90 years and 100 years and 150 years of institutional practice overnight. But the only way you do change is if you're honest, and if you position yourself for accountability.
Right.
And so I appreciate you laying out these entry-level metrics, but I think those entry-level metrics speak to a broader problem. And Dr. Woody, I'd love for you to chime in here as we talk about racism being the reason. Again, like for real, like we know this already. And when we frame the solution in the midst of the problem, we already can't be revolutionary. So when I hear people say they're anti-racist, I'm like, so you telling me what you're not? What the hell are you? If you're anti-racist, what are you? Are you revolutionarily black? Are you revolutionary for the people? Are you, what is it? So as we start trying to reimagine what access looks like, and changing metrics based on that reimagining versus changing the metrics based on racism as the root, does that have us look differently at what metrics should be?
Yeah, I think it does. That's a complex question. I'll try to.
Which is why I brought it to you.
I'll try to pick off a few pieces of it. First, I do want to comment on this. What we in the academy. Okay, now I'm putting on my university professor hat for just a minute. But in the academy, we used to refer to it as the R word. Now, I got started in the university, as I said, in the mid-'70s, and I was fortunate enough to be with a group of black researchers at University of Michigan led by my mentor, Dr. James Jackson. And from day one, we were obsessed with the R word. The reason we called it the R word, because in those days, and for many decades to follow, when we were in a racially mixed setting, nobody wanted to hear us talking about racism, but we were obsessed with it. So I share your feeling that when I actually started hearing the word racism spoken out loud, primarily I think because of George Floyd, my colleagues, my white colleagues coming to me and telling me about racism, I would say, I wrote my first paper on racism in the 1980s. I mean, so far back, I can't even remember. So at that moment, I had to make a choice. Am I going to be pessimistic or optimistic about this? And I chose to be optimistic, even though I had a deep sense of cynicism about the whole thing. So there are two ways to look at this, and there is a downside, but at least we're talking about it. As far as what to do about it, I mean, I did prepare some closing remarks, so I'll be brief and talk about it later. But I'm a public health person, which means I'm not a clinician. I'm not a service provider. All of my research that I've done throughout my career, I have collaborated with clinicians. And I like to tell people I never could muster up the courage to be a clinician. I could barely muster up the courage to be a consumer. So my hat's off to anyone who's actually going to take on the awesome responsibility of trying to help those of us who show up in pain. So thank all of you for that.
Jeff, can I add a little something to what Woody is saying? Do you mind in terms of access?
As long as Woody doesn't mind you interrupting him.
No, I think I was going on too
No,
long.
see, I vibe off
I'm
of
glad
Woody,
the
so I
vibe
know
is
that
there.
pause. That pause meant intro for me.
Please.
Thank you.
You're welcome.
I love the way that we're describing the idea of access, right? And I think that what we need to sort of keep in mind as a frame is that there are individual and interpersonal levels of racism, and then there are systemic, institutional, and structural levels of racism. And when we talk about access, and I think what both Woody and Bukata, I'm gonna get it because I also have a unique name.
Yes.
Are talking about are those structural and systemic levels, right? But we also need to understand what kind of individual barriers get in our way when it means to us seeking help ourselves, right? So let me take you through the process. I am struggling with a conflict, an issue, an interpersonal problem. I'm having trouble in my relationships, in my marriage, in the workplace. And after I've contemplated for weeks, maybe months, right, about what I'm going to do about this, I talk to my friends first. Maybe I'll talk to the pastor or my faith healer or whatever I believe in. I might call somebody who knows somebody else who may be a therapist, but not really. And I might call them as well just to check in, and right, we do this because the last thing that we want to do is pick up that phone or get online and make that appointment, because inherently in our subconscious, we've been made to believe that seeking help for mental health or any stress related to our lives means we're crazy. And whether that operates, in your conscious or in your subconscious, it does interrupt access. And so I want to be able to name that here, because we can look at the way that structures and systems change their way and increase access. But until we have a level of acceptance and love and affirmation for ourselves that we are worthy of seeking treatment, that we are worthy of healing, and that we are worthy of engaging in this journey, because as a community and as individuals, we must get there in order to tackle what now is called a syndemic. So not just COVID, the pandemic, not just racism as another public health crisis, but the mental health infrastructure falling apart. We've got to do something different. So it begins with us. And at the same time, we all in this panel have a responsibility to spearhead the change in systems so that access can be granted.
Can I add something to what Woody said too? One thing that struck me, Woody, when you were talking, and this is the clinician in me, you said we were all obsessed with it, talking about racism. And I thought about, I think it's the Malcolm X quote, which was, when there's a knife in my back and someone only has pulled it out halfway out, I'm not going to pretend like there's not one. And it's not so much that we as Black folks are obsessed with racism. We're all walking around with a knife in our backs, right? And so either we have to talk about it, be aware of it, or we're all living in, we're all taking the blue pill. We're all pretending like it's not there. So I think it's not so much as an obsession as you are trying to take the knife out of your back. That's the way I was thinking about what you were saying.
And I like both, because at what point are we supposed to pretend like we're not Black? No, seriously, right? I mean, I think that in some of these mixed spaces, there's this thing that, well, you keep bringing this up, and I'm like, well, it won't wash off. So at some point, you got to understand this is who I am. Yeah. And I think to the point that Dr. Akbar created, not just as citizens seeking access, but as Black professionals, as Black clinicians, as Black policymakers, as Black academicians, we can't be timid about the fact that this is who we are, and the work. And if we don't bring it up, they'll forget. And we could go down that road.
Well, and they're hoping we'll forget too.
Oh, they do.
Yeah.
It's a shared delusion.
They invest in us forgetting.
Yeah. And remember,
they pay people to forget.
the mental health system was never created for us, right? In fact, if you look historically, it was created to put our people in asylums, you know, and if you look at the history of the American Psychiatric Association, not psychological, you will see that, you know, there were specific diagnoses that were given to the enslaved based on appropriate behavior. If I'm running away from enslavement because I fear getting killed, lynched, whipped, etc., that was considered a diagnosis called drapetomania. I mean, how insane is that? Imagine like what is actually happening in the recesses of our minds, but that what we pass down in our DNA. I mean, we know through epigenetics that we are passing this trauma down one generation to another. So I mean, to your point.
But stay there for a second, right? Because if we recognize that this was part of a broader strategy, so the medical community, the mental health community had to create narrative to justify continuing to enslave human beings.
Correct.
And the broader public could not embrace that if you did not say these people are not people. And so we saw it transition from formal slavery into the insurance community, that black people are uninsurable because they didn't really care about things. I mean, all kinds of manipulation of data and research and study and brain science to say that we were less human than everyone else, so you could continue to treat us as. I guess I want you to stay there, because as we talk about how we turn the tide, is it enough, and I'm leading here, for the APA to say sorry? Or is it enough for providers to say sorry? When we recognize that that isn't making the difference in changing the narrative from the actual industry about what you've done and how that narrative has persisted and continues to persist, not just institutionally, but culturally. So at what point is there legitimate, very public challenges to old research? Publishing of data that changes narrative. And if that's happening, what are some of the sources that those in this room may or may not know about? If it's not happening, how do we get there?
Yeah, I mean, I think those are all really good questions, and questions that we asked ourselves when we did the apology. I mean, we understood that an apology, again, as I said, without action was meaningless to people. And it was really difficult, spearheading this work, making sure that I was being not only true to myself. I came from the clinical world, so I serviced multiple of our folk all the time, and had to understand the role of racism in treatment, right? So that I wasn't diagnosing somebody with anxiety without understanding that maybe they're anxious because they have to deal with microaggressions every single day at work, and they can't even help themselves, and they're trying to do all of this. Now imagine if you were having that conversation with a white clinician that wasn't culturally competent, right? So the conversation has to change, and I understood that. And leading this work at APA, it was important for us to have accountability around this work. And accountability, as you know, is not easy to implement in a system that has a lot of levels and bureaucracy. So what we ended up doing is moving the apology past just a resolution that was passed. Our council passes resolutions in order to make it policy into the association. So we couldn't just have like a paper that said, sorry, we're going to publish it in the news, and thank you very much, I'll have a couple of those media, sound bites. We needed council to pass that policy. And they passed that policy on racism at 100% unanimous vote. It's historic. That has never happened in our association where a resolution was passed. When resolutions are passed, we're able to take positionality around those issues. And now what we're building out is an extensive racial equity plan that looks at the scientific enterprise and the research enterprise, that challenges publications and who gets published and by when, that looks at the fact that our field, psychology, has under 5% Black psychologists. Y'all imagine that?
Yes.
Under 5%. How are you going to seek treatment for somebody that's going to understand your story, your history, when under 5% is represented by Black psychologists? We got a lot of work to do, Jeff.
Oh yes, we're gonna stay there too, because I want to say this, and I want to be honest with the audience. We've gotten till 12:30. Am I right? Okay. And I want to make sure that you all have the opportunity to ask questions, because I don't know about you. I hate when I'm in a panel and they say, "Yeah, now it's questions, but it's only 2 minutes left." So begin to have your questions set, and I'll let you know when we're opening. But there's so much for us to discuss here. We can't discuss everything, but I do want to get to that point. I think we've seen similar realities when we talk about Black men in the classroom. You've got about 2% Black male teachers in America, and so when you start talking about investment, I've been part of something where it's like, well, wait a minute, do we invest in creating more Black male teachers, or do we make sure that 20-year-old white women don't kill our babies? And so Is it an either or? Is it a both and? And do we understand what the investment versus the ROI looks like? Similarly, in the clinical space, when we look at the numbers of Black clinicians, to get us to 10%, just by way of training, matriculation, board approval, and the like, to get to that number is daunting. What do you all see as kind of the delineation between how are we getting, and if anybody in this room is honest, you've had a Black clinician that didn't know nothing about your cultural experience. So there's also the reality of which Black people are we talking about, which people of color are we talking about, what their experience is, and how that connects to me. And so where do we, in you all's mind, and I'd love for anybody to take this, kind of create this delineation of this both and approach to how are we preparing more Black clinicians, but what is the pathway to ensuring a level of cultural competency within certain institutions and training so that no matter what you are given some level of competency to help you serve our community?
I'll take that
Please.
first one. So one of the things I think it's helpful for folks to know is essentially when you're talking about seeing a therapist, you're going to see one of three different types of people. So you're going to see a psychologist, you're going to see a master's level clinician, or you're going to see a psychiatrist. Most people don't see a psychiatrist for therapy, generally speaking. But so you're going to see either a psychologist or a master level. Now, for a psychologist, to get into a PhD program is ridiculous. Okay, so you have to have an incredibly high GPA, right? You have to do a ton of research. And what happens is you get a bunch of people who get into a PhD programs who are good researchers, but not necessarily good at talking to people. And so, I'll call on the APA to think about changing what it means to be a clinician, because those standards have a cascading effect. Because for me, my senior year in college, I had 3 jobs. Ask me if I could do research. No, I could not. One of the things is getting into a doctoral program for clinical psychology is nearly impossible for most students of color because they've had to work. They can't maintain those types of GPAs. They can't work for free over the summer in order to get the experience to get into a doctoral program. So they have almost zero chance. And then you have a master's level degree, which costs $40,000, $50,000 a year. At the end of 3 years, you're $120,000 in debt and you're making $65,000. That is why people aren't going into, because if you are an upwardly mobile person of color or Black person, you're not going to go into a low-paying field. And so I think, I hope I'm answering your question, but the lack of capacity and the few clinicians of color is systemic, driven by systemic racism. It's driven by lack of opportunity, and it's driven by most people who are smart. They're like, well, I'm going to go into finance because I'm going to be able to help my family instead of making $65,000 a year and working my butt off and barely being able to support myself in retirement. So there's a cascading effect here, and I think that there's a lot of ways that we can ameliorate this problem by talking about student loans, by changing the way that we admit people into a graduate program. And I'll add in young, I'm representing young people here. They actually don't necessarily want to see a clinician at this point. Young people of color, Black people are telling me that they want more non-traditional healing spaces. And so I think we have to actually change our mindset about, instead of going into clinics, and where you have to receive a diagnosis to get treatment and have it be paid for, they want to go into other types of spaces, healing spaces, which are peer-oriented.
And because I want you to come in, but also the reality of the racism that follows diagnosis. So if you're in a public school, if you're in a public space, that diagnosis following you in many cases, and sometimes, as we haven't got to yet, misdiagnosis following you in some places. So Bukata, please.
Yeah, I was just going to say the both and piece. So one is there is this investment that we have to do in scholarships and getting folks into school, into the pipeline, period, right? Like, how are we providing those dollars to get folks into pipeline, Black and brown folks into that pipeline, supporting them through that to get there? Because one of the other things, a lot of it comes down to support you get while you're in the process, and can we do that better? And then the other thing, at least from a health plan standpoint, is how do we begin to either through claims or access and utilization to other methods. So we are now looking at we have doulas as a claim benefit. We have community health workers. We're looking at traditional healers. Like this idea of, as a plan, being more creative and more open with the network in which we say this is leading to better health outcomes. I think, at least from sort of my brain and the work that I do, is how do we do that both in the moment, provide relief and remedy, and then invest in long-term solutions so that in 20 years, we're not still talking about pipeline and only 5%. We've actually invested, partnered, us provided internships and jobs to folks who are looking to get into those fields.
So I want to ask about this preparation component, because I think that's huge as we start talking about equity and our folks being served. But at this point, I want to let people know there's a mic in this aisle here. So if you have questions, begin to get in line. I will open it up very shortly and provide you with the rules. But as we talk about the clinical approach, and especially young people, you all tell me if I'm wrong, because there are a lot of people in this room smarter than me as it relates to this, but from what I have understood, so much of the training of clinicians is about coping, and about engaging single trauma. I don't know a black person with single trauma.
Correct.
And so to think that a clinician can engage focusing on single trauma is confusing to me, but you may help me there. The second thing is, when we think about what coping means, and especially young people are like, I saw my parents cope their whole life, I want to overcome. And so how is the industry looking at the training approach to therapy to look at a overcoming model versus a coping model, especially as we have some generational shifts in expectation of therapy?
Yeah, I can take that. I mean, I think that for the most part, when we look at training programs, and Tia, I appreciate what you're saying. I mean, on average too, it takes about 13 years for you to complete, all your coursework as a psychologist. And it is the second most competitive program outside of veterinary school. So it's really challenging, right? And then once you get there, you have a person like me that has overcome every single barrier. I came from poverty. I grew up in the hood in Brooklyn. My parents were immigrants. I was abandoned. I mean, I can go into the whole story that many of us could relate to. Finally, I'm like, I want to help people because my lived experience allows me to connect with them in a way that maybe another clinician wouldn't. And you get to a PhD program, and then you're told by your white professor that you don't have the pedigree to be in this program, and you need to reconsider whether this is the right route for you. Well, imagine had I listened to him. Right? We wouldn't be here having this discussion, right? And so I think that what's important is that, we do have to understand that single traumas are not the norm for people of color, especially for Black people. In fact, when you look at data that comes from adverse childhood experiences, this is something that maybe you all know about. If not, I will send information on it. On average, Black folks experience what we call complex trauma, 2 to 3 on average traumas at any given time. Imagine the number of things that you're processing, but you're still expected to show up at work, in your community, as a parent, as a caregiver, as a partner, and somehow do something with that trauma. I don't know what's happening with it because it's still very present. And so we do have to expand the training, and we have to expand the workforce, and we have to make a commitment for systemic change around this. So I want to, acknowledge that. And one of the things that we're closely looking at are partnerships with HBCUs. Completely if we ever had an ecosystem and an active audience about where Black folks can actually move into the pathway of clinical work, it would be at an HBCU. So why not make the investment monetarily and in other ways to create pathway programs through the HBCUs or minority serving institutes?
So let me do this real quick, 1 second, because I've got 5 people in line. I want to make sure I get to as many questions as possible, and you all still have closing remarks. Okay. So what I'd love for you to do is tell me your name, where you're from, and your question as quickly as possible. The first 3 people, one after the other. You all can, each one of you can answer each of those questions, and we'll try to get to the other two questions or anyone else in line. Yes, sir.
Hello. My name is Hatim Mansouri. I'm from San Francisco. I represent the San Francisco Human Rights Commission. Speaking at HBCUs, I graduated from Morehouse last year,
All
so I'm very
right.
excited.
I'm a
to be
FAM
here.
graduate. Hello.
Thank you. My question is about the diagnosis of Black people and how a lot of times we're overdiagnosed and misdiagnosed. So my question is, when you're talking to these people and you're diagnosing them and you talk about what is the cause of your anxiety and such, and you know that primarily a lot of the reason is because of racism, do we still diagnose them with the anxiety, or do we say, do we put an asterisk with asterisk racism, this is because of racism, or do we just say this person is responding reasonably to the racism and not diagnose them at all?
Thank you so much. Next question.
Great question.
Thank you for your comments and the panel. My name is Karen Ray. I'm from Stockton, California, and I am a health expert for two prisons, monitoring prison systems. And my question is access to what? So we have a lot of CBT, a lot of DBT, but it's not culturally diverse. It does not impact. So we're talking about systems in the free world where you do have access but may not be able to get to it. But in the prison system, you do not have access. You go to whoever. And so there, it is not culturally sensitive at all. So are there any, and I do, Dr. Akbar, I appreciate 130 years. I hope it doesn't take another 130 years
Look.
to actually deal with our prison systems, because these inmates will come out and live next door to us, and we want them to be healthy and whole when they come out of the system.
Thank you so much.
Thank you.
Okay, next question.
Hello, I'm Beth Akiyama, and I'm with the Citizens Commission on Human Rights here in Washington, D.C., and I am really encouraged by all of what I've heard here today. And I hope that you're going to be the conscience of psychology and psychiatry, just as the CBC is the conscience of Congress. There's a lot of work to be done there. And I was encouraged also to hear about your talk about the fake science, such as drapetomania and these other sorts of things. And recently, the exposés...
I need you to get to your question for me, please.
Yes, the exposés on serotonin being an issue in the brain that is not, and how it's affected Black people adversely as these labels and these science get more strongly applied and used as more strong treatments that turn out to not be very beneficial in the long run.
Thank you. I'll get another question since that was not a question, but thank you.
I'm sorry, I want to know how it would be addressed.
So state the question for me real quick, because did you all get the question? If you all got the question,
sorry,
I
sorry.
apologize.
How will you address taking up this false science that is in the, I think you have a unique position to do that, and how can you be a spearhead to take up these kind of false science things that are used?
Great. So anybody want to take that question first?
I could take it. So, I mean, you mentioned, so serotonin is a neurotransmitter that lives in your brain, and based on perhaps given your diagnosis, if you go to a psychiatrist who is a prescriber, psychologist, and most mental health master's level providers do not prescribe medication. So your belief system is very different about how you approach mental health. And so if we were to look at racism as an element that either creates or perpetuates mental illness, then intuitively one would think that medication, traditional medication for mental health may not work. I think that, it's very debatable right now out in the field and the research in terms of the impact for our community. But I also know and understand, and we saw this data very clearly through COVID, that we have a lot of mistrust, related to those types of treatments, because historically we've been used for experimentation, right? So I think that, in terms of false science, we have to continue to have these conversations to elevate the reality behind, what has been written and continues to be supported in the research versus what has come to enlightenment related to, these historical diagnoses that were not actually founded in any kind of science. I'll one-up you the drapetomania and then also talk about the bell curve, people indicating that we were intellectually inferior because of the size of our skull, parole, because of so many other things. Medical students just 2 years ago in a research study saying that, Black people have higher tolerance to pain because of their complexion and the thickness of their skin. This is 2 years ago, y'all. I'm not talking about, drapetomania, 100 and some, this is the belief system of our budding medical professionals who are going to see you in the emergency room. So we have a lot of work to do in the field to combat false science.
I want to ask the question about access to what, especially around prison industrial complex and
Can
resources.
I jump in that?
Please, Dr. Doe.
So a little known fact is in California, the number one provider for mental health is our prisons.
Yep.
And so if you really think about that, that question becomes a little bit more salient. And the person who asked the question mentioned cognitive behavior therapy and dialectical behavior therapy, which are treatments used to change behavior. And they're, relatively speaking, culture neutral, right? They don't incorporate explicitly elements of culture. Where it matters is they're a tool. And how a tool is used depends on what? Who's holding it. And so if the clinician themselves, they are culturally competent, they are trained around racism, complex trauma, then CBT and DBT are useful tools. I use them myself for your clients of color, for your Black clients. But if the person holding the tool has no idea that the etiology of this trauma is racism, microaggressions, all these things that are rooted in our history, then you're treating it blind. You're not asking the right questions. And so it's not, I don't know if you agree or disagree, but I do think we have the right tools, but they're not wielded by the right people.
Dr. Doe, can I ask you to chime in on the first question, which was around how are we processing diagnosis when we're taking racism and the reality of racism into question?
I think there's a really great study from several years ago, Minsky et al., and it was, I'm sure you've read it. It's they gave a little paragraph of descriptor of a person. And the only thing they changed was race. So they had the description and they gave it to 10,000 psychiatrists. If the person was Black, they were diagnosed with schizophrenia, schizophrenia. If the person was white, they were diagnosed with bipolar disorder with psychotic features. And if the person was Latino, they were diagnosed with major depression with psychotic features. Why does that matter? What matters is medication. If you're a psychotic, right? If you have schizophrenia, you're getting Haldol, things that can have long-term effects on your body. If you are bipolar disorder, you're going to get a mood stabilizer. If you're major depression, you're going to get antidepressant. And so to the point of why is that, I really think it is rooted in racism. I know it's rooted in racism. It's because we as people of color, we as Black people are not seen as human in the same way as other people. So when clinicians are not culturally competent, that means they can't relate to us as a person and are not asking the right questions about what we're experiencing. And so I think I answered. Yeah.
But let me ask this before we get these last three questions and you all go to closing remarks. At what point do we need to look at this not just through a public lens, but through a private lens? And I think what Hurdle is doing and what others are doing is saying, how do we pull private funds and investor funds to create revenue-driven solutions in ways that, frankly, we know we're not often going to get from public health. And we know that existing infrastructure isn't going to be there for us. How much of the answer is that? And that's for anybody on the panel.
Can I just address a little further what Dr. Doe was saying? I think it's also really important for us to expand the way that we look at diagnosis. So, I came as a researcher and as a practitioner before assuming my role at APA, and my area of study was racial trauma. And then I coined a book called Urban Trauma, which looks at it from a very holistic sort of perspective, looking at history, biology, and environment. But not to put you in the hot seat. These diagnoses are important when we're talking about coding, so that if you are a clinician and you have to bill for that session and you can't bill for it unless that that diagnosis is available to you, then you're diagnosing something completely different because by mere desperation, you're trying to get paid for that session and make sure that your client gets serviced by you. So we got to be better, and we have to do better. And now that you all have named racism as a public health crisis, and you have an audience of people that will hold you accountable, we have to make sure that we are advancing. We're advancing the diagnostic code and the type of treatment that we can provide that doesn't always have to be standardized in white communities and then wash down into our community. Because sometimes holistic treatment is going to be so much better than a CBT or an EBT.
So we got to kill one level of racism in order to address another level of racism, right? So really quickly, because we got a brief amount of time left, if you all can very quickly rattle off those last 3 questions, and then we'll go to closing remarks.
Sure. My name is Brittany Kosciuszko, and I work for the Center for Policing Equity, where we take qualitative, quantitative data and looking at racial disparities in traffic stops and their policies. So we do a lot of reimagining public safety kind of forms. So my question is, of course, we see with reimagining public safety alternatives, especially public health is that component, is how do we continue to advocate for more funding or reallocation of funding around those alternatives?
Thank you so much. Next question.
Hi, good afternoon. My name is Daryl Campbell. I am a state representative for the state of Florida. At the same time, I'm also a licensed clinical social worker. My question is how do we get more black men into this field? It is really hard out there to find. Even as a state representative, and with my platform, trying to attract more black men into this field, because a lot of black men are coming to me for therapy, and I can't be the only guy counseling everybody.
Thank you, brother.
Hello, my name is Andre Spicer, the councilman in the city of Compton, District 2. And I was coming because I have a question as it relates to public safety. In my community, I understand that hurt people. And most of the crime that happens in my community is gang related. We deal with trauma after trauma after trauma, and none of this is addressed. I'm looking to provide a resource that would be little to no cost or free for the people that are most affected in these crimes, specifically to that community. I didn't know if there was any programs available now that I need to know about. Thank you.
Thank you so much. So what I want to do is each of you have 2.5 minutes for closing remarks. You can read the ones you already had, or you can talk about, and I'd love, Doc, for you to talk about black men, especially this reality that we have created almost the image of black men to be stoic. And then wonder why we don't feel human. How do we advocate for new or reallocated dollars? Let's go there. So I'll let you, and I'm timing you. So we'll start with Dr. Dole and come this way, but you have your choice about how you want to close out.
I actually think that the person who with the policing asked a really interesting question, because their 988 was just launched over the summer. So it was launched in July, and for folks who don't know, that's the National Lifeline. And there's a lot of qualms about calling it, because if you call and you say I'm suicidal, they will track you down at your house and send police. And so that comes to the idea is, should police be responding to mental health emergencies? No. Obviously not. And there are certain states like Colorado who have mobile crisis units, which was, you call an emergency service, they'll send clinicians to your house and do a wellness check and see how you are. So states are starting to change their minds about how they want to allocate resources. Now, of course, there's resistance to taking money from certain budgets and putting them into other budgets. There is money. It's all about allocation. And if we can actually shift the idea that police should be responding to mental health emergencies and understand, let's take that off of their plate and let's put that on the plate of clinicians. However, then we come back to the capacity issue. So I think I have like 30 more seconds. What I will say is thank you so much for having me. Thank you, Kevin, for inviting. And specifically, we have interventions, we have resources, and obviously we have leaders. We are APA's worst nightmare from 15 years ago. So I'm excited about where we're going. point. I'm excited about where we're going. There is hope for the future. And, you know, we all just have to mobilize, even folks in your own personal life, and asking how the people in your life are doing.
Thank you, Dr.
Yeah, I would say been challenged a couple times as a health plan, and I want to say, like, we want to step up to that. I think as a plan, as a person in the healthcare space, we have to do our part. We are duty bound, and I believe that means changing codes. I believe that means providing access, partnering to diversify the funnel of Black and brown providers and practitioners. And so we commit to that. We've been doing some of that work. We'll continue to do some of the work. I do want to just close in, you know, Jeff, you said earlier, sort of like all of us in this room knew racism was a public health crisis. I don't believe this nation knew that. Right. And so I think part of it is, how do we continue to have this conversation as courageous as possible, so that at least we begin to continue to make progress, right, towards where we are going. I think it's a system-wide effort. It's going to require all of us. I think hurdle. So thank you, Kim, for allowing me to be on this panel. I think more initiatives, opportunities, and support from organizations like mine to solutions like Kevin's is the way to go. Last thing I'll say about capacity and what we're building. In the movement, there was an old quote. It said, "That which cannot be defended should not be developed." I believe we have to be willing to defend, both intellectually, financially, communally. This what we're developing for our people going forward.
Well, and Dr. Akbar, before you go, thank you so much for that, and for kind of listen and talk about myth busting. If somebody asked me, looking at this panel, who's the brother from Blue Cross Blue Shield, I would not pick you.
I appreciate you.
And so I love how people got to feel when they find out they're having a meeting with you and you walk in the room. Bukata kind of gives it away.
Yeah, a little bit.
But the need to push these corporations with legitimate pressure towards metrics that are change management versus programmatic is incredibly important. So as much as I've given you a hard time, I really appreciate the work that you're doing inside the belly of the beast to see some of these changes change. Dr. Akbar.
I'm going to first address the public safety question and then kind of give my closing remarks. I think what we have to understand is that a lot of times we look at public safety from the issue of like adults and police encounters, especially with Black men. But we really have to go back, you know, and you posed a really good question, Jeff, about the educational system. What the data shows, and a colleague of mine, Walter Gilliam, has a lot of data at Yale that suggests this, is that from the time of preschool, Black boys are identified by their preschool teachers as being problematic and a behavioral problem. The highest level of expulsions, not suspensions, not going to the principal's office, expulsions, that means a 4-year-old, a 3-year-old is being expelled from preschool, right? Begins then. What do you think that inherently tells our little Black boys when they can't even maintain their schooling because there's no exception to the normative behavior that they're demonstrating? What we also know is that when we look at Black boys as opposed to white boys, when they are entering into the judicial system, Black boys tend to go into the juvenile justice route, and white boys tend to go into the psychiatric route, dealing with their behavioral issues as a psychiatric problem. So see, the pipeline doesn't start as an adult or when there's an encounter with public safety. It starts to be informed by the time they're 3 and 4 years old, right? So we have a lot of work to do in terms of not just the public health system, the public safety system, but also the educational system, which is a pipeline to prison. And we have to be able to change that from that point on forward. In my closing remarks, what I would say is that we need to make an investment in mental health parity. We understand right now that for mental health provision, the reimbursement rate is so much lower than it is for medical care. We have to clap at that because it's so important that we create parity. We need to be able to invest in integrated care. The first encounter with a person with a mental health diagnosis is not a psychologist or a mental health provider, it's a physician. We have to be able to educate our tribal communities to provide and support mental health education and supports.
And lastly, we have to support legislation that moves mental health acts forward and puts it at the forefront than anything else that we're doing right now in Congress. So our only way to deal with this endemic, and particularly the infrastructure around mental health, is to educate ourselves around these issues, advocate at the individual level and at the systemic level, and let's start breaking some barriers, because it's about time.
I'm going to try to briefly comment on some of the things I heard today and end up with a little bit of my prepared remarks. I want to start with the DSM. I think what I want to say about the DSM is that...
Can you tell me what DSM is for those?
Oh, sorry about that. The Diagnostic and Statistical Manual. In other words, the criteria we use to make these diagnoses. I'm really curious about how the manual is employed, and so I interviewed a bunch of clinicians, some psychiatry, some psychology, and I think you heard today why the next presentation I'm going to do is going to be called, it's a thin line between love and hate, because all of the clinicians I talked to simultaneously both loved and hated the Diagnostic and Statistical Manual. They felt they had to use it, but it was really woefully inadequate. I'm going to be talking at a conference entitled, Who's Setting the DSM, How to Avoid the DSM Trap. And my response to them is, who's setting the DSM trap? And you heard today why we need many more culturally intentional clinicians, because we are the ones who will actually be applying those criteria. Misdiagnosis is rampant. I'm not going to go into all of the data we have on that. I will just say that it is crystal clear that black people, particularly black men, are being overdiagnosed with schizophrenia and underdiagnosed with mood disorder. As a consumer of mental health services, I'll say the one big disappointment for me was that the issues of race and culture were completely avoided. And that was because I really had no way of finding a black therapist. If I can close just a few
Like
comments.
30 seconds.
30 seconds, it won't take me long.
Because Kevin's going to come get me.
Yeah, when I prepared these remarks for closing, the word dream came to mind, and I thought Langston Hughes had a simple but profound question. Simply asked, what happens to a dream deferred? He wanted to know, does it sag like a heavy load? My research says, yes, it does. He asked, does it explode? My research says, yes, it does. My research also shows that one of the most emotionally painful things a black person will ever have to do in his or her life is to give up on that dream. And for me, mental health means maintaining the ability to dream. When the dream goes down, happiness goes down, self-esteem goes down, depressive symptoms go up, and so does major depressive disorder. Racism is a social determinant of health. Social determinants are political problems. Political problems require political solutions.
Thank you. Dr. Over, I really appreciate what you said. Literally on my way to the train this morning, I had to stop at school because a teacher is telling me that Baldwin John Raymond Johnson is a problem. And I said, do you understand age-appropriate defiance of a 5-year-old?
Yep.
Because if a 5-year-old is doing everything a 5-year-old boy is doing everything you tell them to do the first time, something's wrong with him. Something's wrong with him. And what you're not gonna do is this, because I'm the first wave. But there's a mother who's not gonna let you make him a victim at 5 and crush this baby's life. And so whether we're talking about our babies, or whether we're talking about our system impacted people, or whether we're talking about those of us that are sitting getting ready to give birth to babies, or whether we're talking about those of us that are entering the workplace, this is a massive opportunity for us to win. And so thank you all for the policy recommendations, for the institutional recommendations, for the private sector recommendations of Hurdle, and thank the Congresswoman for thinking this was a conversation that needed to happen. Each of you is doing work in a different way, and I really hope that you will identify someone in this room or someone at home that you haven't thought about working with before, that now you say, I have to work with. That you will be revolutionary in your approach to being disruptive, not rhetorically, but executionally. And that last but not least, I think, as many have said, that even in our failure, that we don't fail to see each other. Because if there's one thing that I know makes a difference, even as we're failing, it's love over fear. And so thank you all for your time. Let's give a round of applause to this panel, Dr. Dole, Dr. Ricotta, Dr. Akbar, Dr. Woody, for their contribution. And thank you for you, Congresswoman, thank you so much again for making this space available. And you all please enjoy the rest of your Congressional Black Legislative Conference experience.
Thank you.
Yeah,
It was
great to
lovely
meet you.
meeting
Yeah,
you.
absolutely.
Nice meeting you.
Yeah, let's make sure we connect because
Yes.
again, I was saying we're doing some scholarship.
Therapy as we know it was designed for and by people of privilege. It is filled with invisible barriers that prevent people of color from getting the mental health care they deserve. It is not uncommon for experiences with racism to be glossed over in therapy as too obvious, too complicated, too micro, or just too uncomfortable to approach. This is because most therapists are not equipped to process and support the effects systemic racism has on our lives. At Hurdle, we are changing that. Using a philosophical and scientific framework, we train therapists in cultural humility and responsiveness. Hurdle brings insurers and employers into the model, charting a new way to support people of color in their communities and workplaces. We believe this road leads to greater agency to make healthy choices and live a freer life. The journey starts here. Join us.